Good afternoon, sir. Thank you for providing this platform. This is an amazing platform to share and to learn, to share your experience and to learn more. So, in today's scenario, I'm going to present us 70 years old gentleman, and this is the case of calcified aorto osteal RC CTO. Uh, so, how to overcome the issue is the patient is Aishman patient, and the all the aux means gears were for ETO, so we did not have unfortunately much gears, so we have to go with this case without these things. So this is a 70-year-old gentleman presented with angina on rest since last 15 days. He he had PTCA done to LAD 1 years ago with me only, and then uh, he lost follow up because he shifted to Delhi. So he had angina in Delhi, and he was admitted for angiography, and angiography was done in RML hospital, and he was advised CABG. So the patient was not willing. Again, went to 2 3 hospitals, and he was denied by surgeon also. And because LVEF by 35%, and he's still a chronic smoker with rest angina, getting frequent episodes of angina every day. This was the ECG of the patient. You can see there are changes in the LAD that were old changes, and RCA shows some new changes. And this and this is the angiography. So LAD is working fine. LCX is diffuse disease from proximal to distal segment. This is the LED stent. LED is doing fine, and this was the RC. And this is the RC. Is the same since last 1 year. I reviewed the angiography done 1 year ago, and the status was same only. And I advised him at that time that we will do RCA after 1 or 2 months. But he shifted to Delhi, and he didn't get this done. So again, he had angina at rest, and then so, keeping the aortosteal severely calcified CTO of RCA with angulation and so many side branches. So I choose the guide ALS. I will get some support, but because there is no means space in the ostia, so AL was not getting hooked. It was impossible to get hooked, and it was getting off the ostia frequently, and it was very difficult to reposition this guide. And again, the patient was EF was low, so I cannot give much contrast. So I first tried with the AL, and then Fielder XT, but it was not getting the support, and again unhooking frequently. So I then changed my catheter to JR, because JR was easy to hook, although it was also getting off the ostia frequently, but it was again easy to hook again. So I don't have to give much contrast. Then the journey started, and I know I am dealing with a very challenging calcified osteal lesion with angulation also. And so I started with Fielder XT. Fielder XT was not going. I took 0.85 CTO balloon for sport, but it was not giving much sport because the ostia is almost from the very beginning. There was no stump at the ostia. From the very beginning it was uh, uh, close. So then I tried with field Gaia 2. So with very much difficulty, Gaia 2, I was able to negotiate the lesion. And again, as we can see in the angiography, the RC angiography sorts, there is in the distal lesion, distal RC, there is a band like jet-shaped band. So the problem with the GAI 2 that it is not crossing this band, and it is getting stuck there, and it was also not giving much support that we can uh, uh, I can negotiate the balloon through the lesion, because it was very tight and calcified lesion, not allowing me to allowing 0.885 balloon to negotiate. So again, the guide was getting off the ostia, and it was giving me nightmares. So what I did, that I now don't have option to use microcatheter, because the patient is Aishman, and there was no Ox microcatheter available in the shelf. So now I tried with the CTO balloon to cross as much as it can, and to pre-dilate it, so that we can at least overcome the initial calcium hurdle, so that I can use some workhorse wires to exchange with this Gaia 2, because Gaia is not going beyond this band. And at one moment, I made a loop with the Gaia, but again the loop was not going, because the distal RCA is a small vessel, and Gaia loop was very hard. So I didn't push hard, because it can cause injury to the vessel. So what I did, I took uh, my workhorse wire, run through over a balloon, and I passed the pass run through until it went, and then I just pulled out Gaia from the mid portion, where it was very calcified. It was the nervous portion, and just putting the Gaia just out of that portion, and I just uh, uh, negotiated the run through with the help of 0.85 balloon, and with much difficulty I was able to cross the lesion with the run through. Now there was some sea of relief, because now I can use hardware with much force, so that there is no chances, there is no risk of perforation. So after that, I started pre-dilating, but again, it was not allowing even point smallest balloon. I have 0.85. It was not allowing. I opened 2.85 balloons, and it was not allowing till the initial portion, in proximal portion. So I keep on pre-dilating, keep on pushing the balloon little bit. It was going down. It allowed till the mid portion, tightest mid portion, and then I now I was able to reach the mid RCA, where it was the tightest portion, and I pre-dilated it, and then I took a shot. Sorry, this. Then I pre-dilated the proximal and mid portion with 1.5 balloon, so that if in case a wire, and because the assembly was coming out of the RC, because so severe calcification, any balloon I was trying to push in the RC, it was pushing the catheter out of RC. So I just prepared proximal and mid RCA, so that it won't cause any, much problem. Then this was after redilatation of proximal and mid RCA, and we can see there is another calcified narrow point in just after the mid portion. So this was again giving me nightmare, because nothing was crossing there. Now I will show this. Yeah, this is the 0.85 balloon, and it was not crossing that distal narrow point. Again, I have to take one more N balloon, and then with great difficulty, I was able to cross this area. This is not allowing. It is throwing the catheter out of the ostia. So after uh, uh, few pre-dilatation at this narrow point, I realized that it is not going to allow me go beyond this point. So I took a buddy wire, uh, all star, I think the best buddy wire, and I just crossed this point. This point was calcified but allowing the wire to go. So with this buddy wire I was able to cross that point, and then again I pre-dilated by 0.85, then 1.25, then 1.5, then by 2, and then 2.75, and then 3. So I did a severe pre-dilatation because the lesion was severely calcified. Now the issue was, even after pre-dilating with point 2.75, which is the vessel size, distal vessel size, the calcium was not giving away. So I decided to keep the body wire inside so that it will help break calcium. It will act as kind of scoring balloon, and I pre-dilated with the high pressure like 28, 30 till 30, and then with the help of this wire I was able to break most of the calcium. And after that, this is the scenario where I feel that now it's time to go for stand deployment. Then again, that was not the last nightmare. The stand deployment was even more tedious process, because the calcium was not allowing anything to go. Then I cannot exchange the guide catheter also, because there is a lot of dissection because of high pressure pre-dilatation. So what I did, I make loop of JR, so that I can take help of aortic root, and I pushed RCA gently, slowly over the assembly of two wires and balloon and this stent, so that it can make a loop, and the aortic root can give me a spot. And then gently, with constant pressure, I was able to negotiate the stent 2.75 into 36 in the distal RCA. So I was able to cross the stent till the point I wanted to put it, and then I deployed the stent. I deployed it at little high pressure at 16, 18 pressure. So because I know it will not allow me, it will not allow.
Tejvir, can you run it fast?
Yeah, yeah, yeah. It will not allow balloon to recross for post dilatation, and then I started for proximal RC. Proximal to mid RC stent was again the same scenario. Calcium was not allowing the stent to go, and then again the same things repeated, and I was able to cross the RCC calcified proximal to mid stent, and the stent was 3 into 36. So this is the ostial placement. Then this is stent deployment. Stent was deployed at 18 atmosphere, so that it can allow me to go with the post dilatation balloon. And after post dilatation with 3 and 3.5 balloon, this was the final shot. And this is the final. So Aorto Steel
Can you
CTO
can you
is
show the final shot more clearly? Because
yeah,
it's
yeah, yes, sir.
the distal vessel.
I took with because it was not visible. Patient was smoker and chest was very bad, so I took with the
Yeah, distal also there's a disease.
yeah,
Okay,
yeah. Distal vessel is also diseased.
okay, fine.
Yeah.
So this is it. No,
Yes, sir.
very clearly, Tejveer, for the sake of time, we'll discuss more rather than your last slide. So I think very clearly it's a heavily diffusely calcified vessel, and going into these vessels and playing with this vessel is not easy, and especially without the decalcified gadgets. I think
Yeah,
without
yes,
aorta, without orbital, without IVL, it's not easy. It's a really a big challenge to keep dealing with these vessels and very frustrating at times because nothing advances through these vessels. But
yeah, yes, sir.
and if we look at this, what your case reminds me of the latest trial, the Eclipse trial, which clearly mentioned that even without these gadgets, the calcium cutting devices, ROTA or orbital or IVL, if we remain very patient and use lot of non-compliant balloons, still we can actually create lot of cracks in the calcium. Although then the time limit is very high, the effort is very high, the radiation dose increases, but then the results still we can get a good result even without the devices. Your case is a testimonial to that. So, but very
Yeah.
beautifully done, Tejveer. Karan, are
Thank
you
you, sir.
there?
Thank you.
You want to say something on this?
Yes, sir. It was a very well done case, sir. Actually, we have all gone through this phase. We have all struggled with calcified RCA without any gadgets in the beginning of our careers. So, very well done, actually, I would say. Very patiently you have done. And also, RCA definitely, because the JR catheter doesn't give a lot of support, so it is difficult to always negotiate hardwares and all. But a very well done case.
Amjad
Thank
is
you.
there?
Thank you.
Amjad has joined? No. Tejveer, really good case. And
Thank
I
you, sir. Thank you,
it
sir.
must have taken 3-4 hours of hard work.
Yeah, yeah. It was 4 hours, and the case took hell out of me. That was a difficult case.
Hope your back is good. Your back is
Yeah.
not paining.
Yes, sir. Yes, sir. Thank you.
Okay. Okay, we'll come after this, after we finish all that. But it's a beautiful case, and you remain a contender for a Best Case Presenter Award. Let's see.
Thank
Okay.
you, sir. Thank you. Thank you, sir.